Hello, everyone, and welcome to our Zoom webinar. My name is Professor Ann Kargosian, and it is my privilege as the director of the Promise Armenian Institute at UCLA to welcome you to the second of this year's lectures provided to us by our PAI-supported researchers. This lecture is entitled Healthcare Challenges and Opportunities in Armenia, Contributing to Evidence-Based Policymaking, to be presented by Dr. Haley Tupper, a UCLA General Surgery resident and one of our 2022-23 PAI postdoctoral scholars. And there will be an additional short research presentation by Nathan Chu, a senior UCLA undergraduate student majoring in human biology, who was one of our undergraduate research grant recipients for the 2021-22 academic year. Dr. Tupper and Mr. Chu will provide for us an overview of their research on different aspects of healthcare in the Republic of Armenia. For Dr. Tupper, there will be a focus on the potential for universal health coverage and different approaches for that development. And for Mr. Chu, there will be an emphasis on his research on lung cancer screening among male smokers in Armenia. We are also delighted to welcome to our virtual stage Dr. Shant Sheherdemian, our Promise Armenian Institute's inaugural Associate Director for Healthcare Outreach and the research mentor for both Haley and Nathan. For today's webinar, I am grateful to note the co-sponsorship by ARPA, Analysis, Research, and Planning for Armenia Institute, the Armenian International Medical Fund, or AIM Fund, and the Armenian American Nurses Association. And on behalf of our PAI team here at UCLA, I would like to acknowledge our presence on the traditional, ancestral, and unceded territory of the indigenous Gabrielino Tongva peoples. And especially at this moment, I would like to express on behalf of our UCLA Promise Armenian Institute family, our continued horror and outrage at the humanitarian crisis that was triggered on December 12, 2022, by the blockage of the Soul Mountain Road linking Artsakh or Nagorno-Karabakh to Armenia by Azerbaijani activists. We once again call on the international community to accelerate humanitarian interventions and to amplify pressure on Azerbaijan to end this blockade to enable the ethnic Armenian population of Artsakh to live in peace and safety. And now back to our webinar. My colleague, Dr. Shant Shehardimian, will provide a formal introduction for our speakers in a moment. But let me note that for those of you watching live via the Zoom webinar platform, you have an opportunity to send questions to us by clicking on the Q&A button at the bottom portion of your screen and typing in your question. Please be sure to be as specific and succinct as possible in your questions, and we will direct as many of the questions as are practical to our speakers when they are finished. We anticipate that the webinar itself will take around 50 to 55 minutes, after which we will begin the Q&A portion of the event. Also, please note that this event is being recorded for future viewing at our Promise Armenian Institute website and YouTube channel. And in the unlikely event that the Zoom webinar drops for any reason, please just connect right back to the same link, as it will put you back into our Zoom session. And now it gives me great pleasure to turn the webinar over to Dr. Shant Shehardimian. Dr. Shehardimian is the interim chief and an associate professor in the UCLA Department of Surgery, Division of Pediatric Surgery, and as I mentioned earlier, is the inaugural associate director for healthcare outreach for our UCLA Promise Armenian Institute. Dr. Shehardimian joined the pediatric surgery faculty at UCLA in 2014, and his clinical interests include neonatal surgery, minimally invasive surgery, and surgical management of inflammatory bowel diseases. His research interests focus on developing innovative treatments for children with short bowel syndrome. Dr. Shehardimian is also an active global health researcher focusing on health systems, strengthening and development of quality improvement initiative in post-Soviet nations, including Armenia. He has focused on this area during his tenure as a senior advisor with the Ministry of Health in the Republic of Armenia in connection with his responsibilities as our PAI Associate Director. And as I mentioned, he has also served as research mentor for both of our speakers today. So, Shant, I will now turn the webinar over to you for an introduction of our speakers.
Thank you very much, Professor Karagosian. I am doubly excited today because I get the honor of introducing our extraordinary researchers, Dr. Haley Tupper and Nathan Chu. But I'm also equally excited about the work that they have been doing and the approach that has been taken, a very novel sort of approach in terms of embedding our researchers and our expertise within the Ministry of Health in Armenia and starting to create and generate data that will directly and in real time be used to inform policy making within the Ministry of Health and the government of Armenia. Very often our approaches have been more reactionary in terms of addressing needs that any healthcare system has, of which there's not a shortage here in Armenia. But this is somewhat of a novel approach in that we are being proactive and sitting side by side our counterparts and decision makers and policymakers here in Armenia to help do research that will be used again in real time to help make better decisions for the betterment of health and health outcomes for all of the citizens and population of Armenia. So my partners in crime in this work and our speakers today are, as mentioned before, to start off with Dr. Haley Tupper. Haley is one of our surgical residents who all get to spend a couple of years doing various forms of research in the quote unquote lab at UCLA. Haley has an interest in global health and had applied for and received the funding from Promise Armenian Institute to spend her research time here in Armenia. By background, Haley has an MD from Boston University and am I mixing that up? An MPH from Boston University, followed by an MD from Mount Sinai. She has an interest in global health and has done both global and local service and research with underserved populations in Cambodia, as well as in inner cities in New York. She has been here at the Ministry of Health over the past year, and I will let her give the details of all of the various activities that she has been involved with. Nathan Chu is an undergraduate student who, despite all of the obstacles and hurdles that the COVID pandemic had thrown our way, persevered through and completed successfully a very interesting research project that has already landed on the desks of policymakers here in Armenia and will hopefully lead to some changes and implementation for new models and new approaches to cancer screening in Armenia. Both he and Haley will talk about the burden of oncology and cancer-related diseases, particularly lung cancer. And so I look forward to hearing both of them present their work starting now. So with that, Haley, screen is yours.
One minute, let me just get the right things set up. Okay, so without further ado, we'll get started on supporting universal health coverage, vertical and horizontal approaches to health system development in Armenia. So this talk is really going to be a buffet of a lot of the ongoing work at the Ministry of Health and within Armenia. So apologies for the variety, but I think it gives a good picture of what's going on. So first, I want to make sure we're on the same page with some nomenclature about health programs. So this talk will go through vertical approaches and horizontal approaches. Vertical approaches are disease-focused. These are things that you're probably traditionally familiar with. It's like PEPFAR, which focuses on HIV/AIDS, or the Global Fund, which is focused on TB and malaria. So there's pros to the vertical approach. They have a clear mandate with measurable goals. It has historically massively increased global health funding. It stimulates research and development, and it has improved access to specific cost-effective interventions. And it can strengthen disease-specific health system elements like the cold chain for vaccines. There are some cons though too. It often creates many parallel redundant systems. It can weaken the national healthcare system, and it really can complicate national planning. The second approach is a horizontal approach, which is really systems focused. So the pros here are that it seeks to strengthen the national healthcare system and fundamental building blocks like the workforce, information systems, and financing, and it really focuses on the integration of these building blocks. Cons though are it's a much more abstract concept, it's complex, and it's difficult to measure. So now some people are also talking about diagonal approaches, which we will not really address here, but just so that you know, diagonal approaches are basically an answer to funding mechanisms and the understandable preference for measurable outcomes. So basically an example would be reducing hypertension by 50% by strengthening primary care. So you're using disease-specific goals by means of health system strengthening. And none of these approaches are inherently bad. They just need to be used in the right time and place. Vertical programs definitely have a place as long as they're carried out with the rest of the health system in mind, knowing that one project will always take away attention from another. Okay, so for a little bit of background, universal health coverage, what is Armenia up against? It wants to roll out universal health coverage by 2027. Universal health coverage is basically where all people have access to the full range of quality health services they need, when and where they need them, without financial hardship. It's a stepwise process. You cannot cover everything at once. And it comes from, in 2015, universal health coverage was established as one of the Sustainable Development Goals. The goal is basically to improve health outcomes and avoid catastrophic healthcare expenditure. So now let's look at some quick illustrative facts about the Armenian health system. We're going to go first disease-focused and then health system-focused. You'll see the same theme where we do vertical and then horizontal approaches basically throughout this talk. So if we go about the disease burden, Armenia's disease burden is overwhelmingly non-communicable diseases. It's 85 to 90% non-communicable diseases. Cardiovascular disease is over a quarter of the disability adjusted life year, which accounts for the health that's taken from someone, not just the mortality. And cancers are the second, accounting for about 16% of disability adjusted life years. Armenia, one of its main reasons it has such a strong non-communicable disease burden is that there's really limited primary and secondary disease prevention. So primary prevention in the case of cardiovascular disease, primary prevention would be preventing high blood pressure with a good diet, exercise, low salt intake, not smoking. And secondary prevention for cardiovascular disease can include things like controlling the blood pressure with antihypertensives, prescribing aspirin to prevent strokes, heart attack, heart failure, et cetera. So some other statistics with this disease burden is, for example, only 30% of primary care physicians in Armenia discussed tobacco use and cessation in the last year, even though over 50% of men smoke. So there's not a lot of primary prevention happening there. And then with the secondary prevention, 80% of patients with known hypertensions did not take their prescribed medications in the last week. So there's a lot of reasons for that, but we will get into some of them. Okay, now for more of a horizontal look at Armenia's health system with some quick facts. So Armenia has really low public healthcare financing and high out-of-pocket expenditures. So about 80% of total healthcare expenditure is out of pocket. This is actually only the only countries that have a higher out-of-pocket expenditure are Myanmar and Yemen, according to the World Bank. In the United States, it's about 10%. And 4% of all total household expenditure is on outpatient medications. That's a lot. So that includes things like rent, but 4% of their income is their expenditures are going towards medications that are in the outpatient setting. Another important statistic that's illustrative is there's really low primary care utilization, and with that, high specialist and inpatient care utilization. So about a third of patients bypass their primary care doctor to directly seek specialist care. And 42% actually reported that they most recently received medical care in a hospital or an ambulance, so not in the outpatient primary care setting. Care is often uncoordinated and the quality can be unregulated. So there's been no provider licensing or registration since 2001. Only 18 pharmaceutical samples were tested in 2008 to 2010, and of seven of those 18 actually failed to meet quality standards. So that means people are taking medications that may or may not work. And then there's no required registration of non-governmental organization or civil society organizations, which means it's really hard to coordinate and know what's going on. So some of these problems are a legacy of the Soviet systems. Other came about when public spending was necessarily decreased when the GDP was really low in 91, but it's where do we go from here? And then I also wanted to mention that within the Armenian government, that it is up against its own challenges. So this picture on the right is a picture of the Ministry of Health. It's a very long hallway with a lot of doors, and work is generally kind of siloed with low public servant salaries. There can be some limited communication about who's doing what. So within the ministry, between ministry and donors, between intra-ministry, and that means work sometimes get duplicated, not just by the Ministry of Health, but by donors and other multilateral organizations. So as I go through these, facts or statistics that might seem kind of concerning, I want to bear in mind three things. So public health and health system work is very slow. It's not instantaneous. We're not going to get results in 5 or 10 years. It's going to be results on the order of 25, 50 years. These issues are not unique to Armenia. So even though I'm pointing them out in the Armenian context, I don't want to act like these are only happening in Armenia. And we could easily do a similar quick facts activity for the United States or another country and find some equally concerning statistics. So I don't want to leave this talk and feel like we're down on Armenia at all. It's just some of the challenges. Okay, so this talk, we're going to first address some vertical disease-based research. So the three diseases we focused on are all cancer related. There's breast cancer, which has three research projects that we'll talk about, cervical cancer, which has one research project, and then lung cancer, which I'll leave to Nathan. After that, we'll go through some horizontal reform and policies that we've been working on, all basically in the name of universal health coverage. So there are three that I'm really excited about and passionate about. The first is primary care reform. The second is drug procurement, pricing, and reimbursement. And the third is provider licensing and registration. And in the background of all of this, there's the internal capacity building that's happening at the Ministry of Health. Okay, so for every topic, I'm going to give you a little bit of background on it first. So generally cancer. So cancer is the #2 cause of mortality in Armenia, and Armenia does not have a national cancer strategy. So this would include prevention, screening, and treatment. And here are the projects again listed that we're going to go through. Okay, so with regards to breast cancer, we had three specific projects on this. The first was a survey instrument validation, and all these projects are at the patient level. So we're studying patients essentially, not the provider or not the system necessarily. So the survey instrument validation, the second is the individual patient level screening beliefs about breast cancer screening, and third is breast cancer treatment costing. So a little background on breast cancer. Armenia has the 4th highest breast cancer mortality in the world, actually. Among women ages 15 to 49, breast cancer causes 14% of deaths. That's compared to 5% worldwide, and about half of women that are diagnosed with breast cancer will die from it, with a mortality to incidence ratio of 0.5. With regards to screening, so screening via mammogram has been shown to reduce breast cancer mortality. We know it does. About 84.4% of Armenian women that are approximately screening age have never undergone a mammogram. The Ministry of Health is working on implementing an organized breast cancer screening program, but breast cancer screening is not currently covered in Armenia except through some Mars mobile pilots. And then the third thing is treatment. So there's obviously ethical issues of screening without providing comprehensive treatment. What's the point of knowing you have breast cancer if you can't do anything about it? So breast cancer treatment is covered once the cancer is diagnosed. The screening mammogram is not, but once you've proven that you have cancer in Armenia, then some of the treatment is covered. In the outpatient setting, the visits and care are supposed to be covered without a copay. For chemotherapy, it depends on whether you're a special population. The basic benefit package then is supposed to cover 300,000 dram. If you're just not a special population regular, then it's 150,000 dram. Inpatient, it depends again on the population. If you're special populations, no copayment. If you're just regular, then you have a copayment. I want you to keep in mind though that informal payments are widespread. It's estimated that 45% of all health expenditure is in the form of informal payment. So even though we say that things are covered, that probably is not the reality on the patient side. And when you get to the surgery side, about 63% of surgery is paid for with informal payments. So their patients are still paying. So the first study we did was basically a validation of the survey instrument that we wanted to use, which is will be the second study that I'll present to you. So some background for you. The instrument we wanted to validate is the Champions Health Belief Model Scale. This is a widely used model to evaluate individual health beliefs that influence screening behavior for breast cancer specifically. It's been validated in I think 20 countries, and we sought to validate it in Armenian for Armenia. So basically the reason we did this is because evaluating the psychometric properties, which is people call it validating, of a survey instrument before you use it is best practice. So the CHBMS, this survey instrument has 5 domains they assess, and I think you'll see some repetition with Nathan's as well, because this is a common survey instrument, is perceived susceptibility, benefits, barriers, and self-efficacy, and then fear. So the methodology here, it was basically a cross-sectional telephone-based study of Armenian women ages 35 to 65, evaluating the psychometric properties, which in this case are content equivalence, test-retest reliability, and internal consistency of an Armenian language CHBMS. The long and the short of the results, which we published in PLOS Global Health, are that based on these coefficients, The Eastern Armenian version is a valid, internally consistent, and reliable research tool that can be utilized to investigate current health beliefs and perceptions about breast cancer among Eastern Armenian women. So the next step then was to deploy it to actually survey the women with this new survey instrument. So step 2. Basically, the reason we wanted to do this survey is because the success of any cancer screening program depends on its uptake. There could be a lot of cultural barriers and health beliefs that could limit screening participation. And before Armenia goes and rolls out screening, it's important to understand preliminarily what some of the barriers could be. So in the methodology here is basically the same women, the same demographics, 35 to 65, registered in the public polyclinic system in Yerevan, were randomly contacted by phone call to undergo our now validated Armenian language CHBMS survey. The survey also included some demographic and breast cancer exposure questions. So 170 Armenian women completed the survey, and I'm going to go through some of the survey results with you. Not all of them. So this one I'm going to highlight a little bit more, but it has to do with personal exposure to breast cancer. So this was one portion of the survey. So in this part of the survey, we see that people are actually highly aware of breast cancer. Nearly 50% know someone with breast cancer, and almost a quarter know someone who has died from breast cancer. And over 80% have heard about diagnostics that can detect breast cancer early. So women in Armenia, they know about breast cancer. They know people who have died from it. They have friends who have died from it. And they've actually heard that there's testing available to detect it early. The thing is, most people have not discussed breast cancer with their doctor or undergone screening. So 58% in this survey had never undergone breast cancer screening. That may be because it's a little bit later or because we did it in Yerevan, where things are a little bit more accessible. And of those who had undergone screening, a large proportion are from unlisted reasons. So this may be from NGO or CSO screening, things that don't fit under the category of my doctor strongly recommended and referred me. I asked my doctor to be referred. I obtained screening without the formal recommendation of my physician, a family member or friend recommended, or for unlisted reasons. So there's a lot of people that are obtaining screening for none of the first 4. And then 75% had never talked to their doctor about breast cancer and or screening. So even though women are, highly aware and exposed to breast cancer and they know they're screening, it's still not a conversation that's happening between the doctor and the patient. So as I noted, the CHBMS has 5 domains, one of which is perceived barriers. And this is obviously too small to read, but I'm just going to highlight 2 of the main perceived barriers that I found to be most interesting. So the most women in the perceived barriers, as you can see, I'll go back, most of them are not agreeing that this is a barrier. But the biggest barriers, the 2 that women identified, were being treated rudely at the breast imaging centers and being able to afford breast imaging. I think the second one is unexpected. Mammography is not covered. But the first I was surprised by, because people being worried about being treated rudely at the breast imaging centers would stop them from going. So I think that's an important thing to keep in mind if the Armenian government were to roll out screening, is how women will be treated while they undergo this screening, especially if it's at their breasts. Okay, so on to our third breast cancer project. Again, I said this is a bit of a buffet. We're going to touch on a lot of different subjects, and I hope we're keeping it structured. But this has to do with the breast cancer treatment costing. So the background for this is the cost of breast cancer treatment for the patient is unknown. And as they go to decide what they're going to cover under universal health coverage, the Ministry of Health needs more information about these treatment costs, because anecdotally, 150,000 or 300,000 dram for patients is not enough. And we know that the prices vary by treatment location and the type of treatment. So between medical centers, radiation centers, pharmacies, labs, etc. And also, we know that Armenia can't afford to cover all breast cancer treatment under universal health coverage. Cancer care can be very expensive. It's just a matter of deciding in a staged process what can be covered and what needs to wait until they have a bigger budget. So our methods, basically we devised 4 different patient scenarios that are stages 1 through 4 that were designed to cover the breadth of potential treatments with associated cost based on National Cancer Care guidelines, NCCN guidelines. So we had it structured here where we have it by stage and all the potential different tests as a line item. And not every stage needs all of these different tests or treatments or labs or radiation, but we have marked them all to basically be able to cover the full potential cost to a patient in any stage. So there's a few steps in the methodology here. The first one is key stakeholder interviews to establish representative sources of costing data. So we wanted to know where would be most representative. We didn't want to just go ask a random medical center. We wanted to know where women are getting their cancer care and where would be, high prices, low prices, what would be representative of the spectrum. So we've identified thus far potential costing data sources. So we've got public sources and private sources that are going to cover, that are hospitals, they're going to cover surgery, chemo, there's radiation centers, pharmacies, and labs. The next step that we're actually in the middle of is interviewing these representative sources to find out the costs that are associated with each line item. So if it's a pharmacy, do they know the cost of the pharmaceuticals? If it's outpatient pharmacy, then do they know the cost of, for example, tamoxifen for breast cancer? And in this case, the results are pending. Okay, so our next cancer is cervical cancer. In this case, rather than looking so much at the patient side, we're looking at the provider side. So this is provider knowledge, attitudes, and practice. So a little background for cervical cancer in Armenia. The burden of disease here for women ages 15 to 44, it's the second most common cause of cancer-related mortality. Number one is breast. And in this case, there's a really high percentage of cases that are diagnosed late stage. So over half of cervical cancer is diagnosed late stage, which is stages 3 or 4. And this is the highest in the former Soviet states. With regards to prevention, HPV vaccination is one of the best ways to prevent cervical cancer. In Armenia, it's only covered for women. It has a pretty narrow age range, and it was introduced in 2017. But there's a lot of vaccine hesitancy in Armenia. And so coverage in this case is very low combined with other socio and cultural reasons. So only 10% of eligible women were vaccinated in 2020, or eligible girls. For screening, so cervical cancer screening was introduced in 2007. This one is covered under the basic benefits package, and it's women ages 30 to 60 via cytology, and you get it every 3 years. So in this case, only about a quarter of women that are within the age range are up to date with their cervical cancer screening. So there's some work to be done there. The thing is, Armenia doesn't have any system to actively invite patients to undergo cervical cancer screening. So screening rates depend on primary care physicians actively inviting the patients to be screened. And this depends on primary care physicians' knowledge, attitudes, and practice. So the methodology here is a cross-sectional study of fully licensed primary care physicians that were practicing in 12 polyclinics, public and private, in Yerevan. It was based on an Armenian language questionnaire for providers that was adapted from an Iranian survey. And it assessed 4 domains: provider knowledge, attitudes, practice patterns, and demographics. So in this case, 140 providers completed the survey. And I'm just going to go through a few results because, like I said, this is a bit of a buffet. But with regards to knowledge, so when they were asked about the risk factors for cervical cancer, providers generally did a great job with identifying HPV. 98% identified HPV, which is correct as a risk factor. A little more concerning, though, was that 29% identified the use of tampons as a risk factor. Another 35% identified improper personal hygiene. So you get the sense there's a stigma attached with cervical cancer here. And I think that's reflected again in the attitudes. 29% answered neutral to strongly agree that it's shameful to be screened for cervical cancer. So there is some stigma against not just the cancer, but also the screening process itself. And in practice, so about half had been trained to do a pap smear, but only 1% performed them in practice. And 98% of providers said they always counseled patients on cervical cancer screening, but this wasn't translating into referrals. If they weren't doing the pap smears, then they were referring them to gynecologists. But 76% had referred 0 to 5 patients for screening in the last week. This is not because of low patient volume. They were most had seen over 50 patients in a week. So 97%, when they were asked why they didn't do pap smears, it was said because it's the responsibility of gynecologists. So 73% also believe there was no benefit to primary care physicians doing pap smears. And similarly, 65% did not believe patients would have more pap smears if family doctors did them. The thing is that primary care is covered under the basic benefit package for the entire population, and specialist outpatient services are covered for defined conditions. So while the pap smear may be covered by the gynecologist, it's pretty routine to have some sort of copay, formal or informal, with a specialist. So most likely, patients are paying more when they need to go to a gynecologist and ask for, if they're not being referred, then they're going to have to ask for it, and then they will definitely be paying. Okay, so lung cancer, again, I'm going to save this for Nathan. Nathan's going to give you a great presentation on the individual patient level health beliefs about lung cancer. And we are going to move right on to horizontal reform and policy. So we've done the vertical disease-based portion, and now we're going to move on to the vertical reform and policies. So I'm going to go through some main projects. It's not all of them. These are all directly related to quality provision of care under universal health coverage. And the goal, like I said, is to roll out the UHC by 2027. So the main subjects here are primary care reform. I'm going to go through two projects. One is the PHC dashboard, primary healthcare dashboard. And the second is some additional data analysis done with the World Bank data. The second main topic is drug procurement, pricing, and reimbursement. And the main thing here is the reimbursement policy, focusing on that aspect. And then third is provider licensing and registration. And I'll be sharing some of the provider licensing roundtable with you that we did. Okay, so with the primary care reform, again, two projects. And first, I really want to tie universal health coverage and primary care together. So universal health coverage can achieve financial protection, but research has shown that in and of itself, universal health coverage does not necessarily change health outcomes. Things that do change health outcomes are improving the quality of care and having a strong primary care system. And then next, I'm going to go through a bit of the SMASH-Go system with you. And I want to give the Soviet Union some credit that the SMASH-Go system was actually one of the first versions of universal health coverage. We don't really give them credit for it. And, there's a lot of negative things about the Soviet Union, but it really was one of the first universal health coverage systems. And then I want to also acknowledge that this former Soviet space, all of the former Soviet states, are really central to the history of primary care reform. The WHO, all their big conferences on primary care have been held in Kazakhstan, the Alma-Ata conference, and then 30 years later, the Astana conference. And the Soviet Union really had a pivotal role in realizing the Alma-Ata conference in Kazakhstan that's really typically not acknowledged. And post-Soviet nations like Estonia, Slovenia, and Kazakhstan have really achieved internationally laudable primary care successes. So there's some good examples of successful primary care reform in former Soviet states. So I think it's impossible to talk about the health system without giving you a little bit of background on the SMASH-Go system. So the SMASH-Go system was named for the first Minister of Health in the Soviet Union, Nikolai Smashko. And it was built as a multi-tiered system of care with strongly differentiated networks of service providers, where each of the 5 levels corresponded to the severity of disease. So you had district, central rayon, municipal, oblast, and federal hospitals. And these were all, in theory, connected by a really sound referral system. And central to this model was the district physician, who was supposed to be responsible for providing and coordinating the medical care for the population in his or her catchment area, which was defined by patient lists. So there was nominally egalitarian allocation of resources, particularly providers and hospital beds, and they really aggressively managed infectious diseases in childbirth. And also, it's important to note in this system, there's the polyclinic, which is outpatient care, but it's both primary and specialty outpatient care. And so in this system, it's dominated by publicly owned facilities. You've got salaried health workers and a high degree of central government administration. And it really did have some early successes. It had this financial accessibility of care. It was assumed that everybody should be able to access care without paying for it. The district physician in theory, was really going to be coordinating the care and was responsible for the catchment area's health. And it really did have successful treatment of communicable diseases and some successes with maternal and child health. It had this dynamic dispensary surveillance, which was a disease-based system of treatment protocols, including monitoring processes and mandatory visits. So for example, chronic diseases, it was very protocolized what kind of follow-up intervals were needed. But it had some early problems. It was very underfunded and it had very weak provider incentives. Also had this massively bloated hospital system with really huge overuse of inpatient care that they're still dealing with today. So then the Soviet Union collapsed, or we haven't gotten there yet. This is before the Soviet Union collapsed. Next slide will be the Soviet Union collapse. So this is how it evolved. Basically, there was heavily centralized governance, but what this resulted in was really limited involvement of community and stakeholders. It was pretty out of touch with individual community needs, and it wasn't very responsive. So this unresponsive bureaucratic administration was often very numbers-based, and it had a huge emphasis on the inputs. They needed to allocate their resources fairly. But the outcomes were kind of missing. It was underfunded. So pretty quickly, there was this growth of widespread informal payments and kind of low quality care. And then once you have informal payments, you really can't do any gatekeeping anymore. And then there was, like I said, this communicable disease focus. At this time is really when there was the Soviet Union was undergoing an epidemiologic transition. So NCDs, non-communicable diseases, were really the vast majority of the burden of disease at this point, and they were largely left to the side, very inadequately addressed. The dynamic dispensary system, even though it was very protocolized, it led to this dependence on these outdated protocols, and it also fails to account for multi-specialty care. It's a very linear progression of one person, and there's inadequate emphasis on monitoring the outcomes with these protocols. This specialist practice, go back. Sorry about that. So the specialist practice in the district polyclinic, like I said, there was a huge over-reliance on specialty care. This district physician that was supposed to be coordinating care and taking care of his patient list really lost his scope of practice and his role in care coordination. And as I noted, once there was informal payments, you really don't have anybody gatekeeping, which is really to say coordinating the care, acting as the quarterback of a patient's healthcare. And the specialist began providing more, quote, primary care, which was really specialized outpatient care. Problem with this is that specialist care, as we know it, is episodic, and specialists neither coordinate care nor act as a quarterback or gatekeeper, whatever you want to call it in terms of the care coordination. And as I said, there was a huge emphasis on inpatient care, which really, with this overabundance of hospital, there's only finite resources, so the result is weak outpatient and primary care. Okay, so then the Soviet Union collapsed, and we see the evolution of the Smashko system a little bit more. So Armenia had a pretty big economic collapse with the Soviet Union in '91, and the public system was necessarily massively defunded. And the result of this is that there was huge privatization and informal payments, and these both just proliferated unregulated. Private clinics often did not have patient lists, so they didn't have a defined catchment area and no care coordination responsibilities. And even when countries grew economically after the fact, Armenia's public spending and the associated regulation and coordination did not rebound. The quality of the medical system declined with this. The inflation basically entirely devalued the paltry salaries of the public medical personnel, and the medical education system somewhat declined. So it made it harder for Armenia to produce a qualified workforce. There was limited scope of the district physician practice and role. And there was limited regard for primary care among the providers and the patients alike. And the polyclinic, which is outpatient, primary, and specialist care, really became equated with primary care, which is not how we would define primary care, really. But I wanted to tell you a good fun fact. Armenia was the first post-Soviet country to offer family medicine training. So there's hope there. Okay, so Armenia has had its own history of primary care reform. Again, transforming this now defunct Smashko system or model of care into an efficient model with high quality primary care at the center is very challenging. And a lot of people have been trying to fix it. So The World Bank pursued primary care improvements, and then USAID. USAID also had significant retraining of specialists into primary care. And the current Ministry of Health really wants to get its universal health coverage established by 2027, but weak primary care has really been hampering the system since independence. And it's really the foundation of good healthcare. So you cannot have universal health coverage without having a good primary care system. So now there's internally driven primary care reform to support this UHC. But even though UHC is an explicit government priority, primary care reform still is not. There was not any specific primary care unit within the Ministry of Health, and they decided it was under the purview of ambulatory care. So in October of 2021, a primary care task force was convened. I'm not sure if you've heard about this from Dr. Shekerdemian or not, but the results after 6 months of working very hard on identifying the gaps in the Armenian health primary care system was 58 action items. So this was developed from a framework that builds on a technical series that was developed by the WHO in 2018 at Astana. And basically they went through and looked at the Armenian healthcare landscape for each of these 14 levers. And then they determined what was needed to achieve that vision. And then they summarized all of these findings. So let's see. And then the government took these 58 action items, you can see, and transformed them into 58 government orders, which are michotsarone. And this was signed into policy. So the big problem is really how to implement all of these 58 michotsarone. So the implementation and coordination is a massive step. Coordination is an enormous issue, as I noted, that with the siloed work, coordination in the Ministry of Health, between ministries, between ministry and parliament, the enormous number of external organizations and funders from the World Bank, diasporan organizations, local NGOs, local CSOs. Coordination is a huge piece of work. And then for any also for any government or organization, this would be a huge project. Like even large companies like Google, managing such large projects is a common problem. So, and a lot of people don't have project management skills, which in this case would be very useful. This is an enormous project. And then finally, the funding and financial planning is another major issue. There's no dedicated primary healthcare reform funding, but all of these changes would require financing. So one solution that we came up with was basically a Google sheet to coordinate everyone. So we are building it out as needed. We can add things like the budgeting, and the goal is to help with project management. So here it's a very zoomed out version. Here is a close-up version. You have the 58 michotsarone, and the goal is transparent project coordination so that other parties can see what kind of work is being done, and so that they can contact the relevant responsible person so they're aware generally of all the other end dates, and also to help just have accountability and stay on track. So essentially, you have the responsible person's name, the department, the michotsarone, and then the start and end date that's written into law. And then you update the project status. And this visual representation of the start and end dates really should hopefully help to coordinate the projects. And the color representation of the project status basically automatically changes based on the project status and then the start or end date. So if it is on hold, but its end date was 6 months ago, then it's going to be red. Similarly, if it's in progress and its start date or its end date was 6 months ago, it's also going to be red. So it really depends on what the current date is and the status of the project. So this was one answer to trying to help the Armenian Ministry of Government coordinate all of their 58 action items or 58 michotsarone. It's still a work in progress. The second thing with the primary care that we were working on was some additional analysis of World Bank data. So to give you a little background, the World Bank in Armenia and several other countries completed this vital signs profile that in partnership with the PHCPI, which is a partnership of the World Bank, WHO, UNICEF, Bill and Melinda Gates Foundation, and their goal, the PHCPI's goal, is to improve primary care. globally. The purpose of the vital signs profile is to compare different countries' primary care systems in an informative and visually appealing manner on a number of dimensions, from like financing and capacity to performance and equity. So there's about 30 countries right now that have active, you can find them on the internet, vital signs profiles. And in our case, we were really interested in the quality portion. So as I mentioned, the two things that have been shown to improve health outcomes are quality care and primary care. So this is kind of the intersection of both of them. So we wanted to look at this quality index. So this is more details about the quality index. Again, this is all the World Bank's work. I will get into our portion of the work. And we wanted to look at the section provider competence. We wanted to know how, we wanted to basically, there's some concerns about the variable quality of primary care providers, and we wanted to know what factors are associated with low adherence to clinical guidelines and low diagnostic accuracy. Because as you can see here, only about 33% of providers had adherence to clinical guidelines, and 36% had good diagnostic accuracy. So the way it works is basically provider competence was assessed by objective structured clinical examinations, which a lot of medical students know as OSCEs, which is basically role play. There's 7 possible scenarios. There was 3 child and 4 adult. Providers were given 1 to 3 scenarios that were appropriate for their training. So for the child scenarios, these were only given to family medicine and pediatricians. And the adult scenarios were only given to family medicine and internists, which are known as therapists in Armenia. So for the diagnostic accuracy, you needed to get all diagnoses per scenario correct to get credit for that scenario. So there was between 1 to 2 diagnoses per scenario. And then for the adherence to clinical guidelines, basically the numerator was the relevant clinical questions that provider asked for that scenario. And the denominator was all possible relevant clinical questions based on a standardized interview guide. I want to note one thing before we get too interested in these results. There was no correlation between adherence to clinical guideline scores and diagnostic accuracy scores for providers, which is a bit odd. You would expect if somebody's adhering to clinical guidelines that they would be more accurate with their diagnosis. So I think we should maintain a healthy degree of skepticism towards these results as I go through them. So this portion is our analysis, our additional analysis. So we wanted to see if there was any provider or facility characteristics that were associated with lower diagnostic accuracy or lower adherence to clinical guideline scores. The variables that we looked at, the independent variables, were provider characteristics. So specifically the provider's position, whether it's family medicine, internist, or pediatrician, the provider's gender, their training level, and then their facility type, this should be education level. The facility characteristics, so facility type, the location, so whether it was rural, urban, or in Yerevan. We also looked at just the 12 MARSs, and then ownership, whether the facility ownership was public and private, and whether the facilities by self-report had the presence of up-to-date practice guidelines. So for the lower diagnostic accuracy, independent variables were the provider's position. So both pediatricians and internists had lower diagnostic accuracy. This was statistically significant. Only p-values of less than 0.05 are reported. And location. So Yerevan had lower diagnostic accuracy. That means that conversely, family providers had higher diagnostic accuracy, and the other MARSs and rural areas had higher diagnostic accuracy. Then if we look at lower adherence to clinical guidelines, it's a bit flipped. So the position that had lower adherence to clinical guidelines was a family medicine doctor, men, those with less training, so bachelor or certificate only, being in a polyclinic or ambulatoria. So the other options were ones that were more associated with a medical center or a hospital, and then the location, so being rural or in Yerevan. The thing is when I think about this data, it seems like potentially providers just asked more questions if they were uncertain about the diagnosis. And if you ask more questions, you get a higher adherence to clinical guidelines score. So I think that we should be thoughtful about these results, and like clinically, at least when I look at the questionnaire and the adherence to clinical guidelines, I have more faith in the diagnostic accuracy than the adherence to clinical guidelines, although I think still we should be skeptical of all of them. So providers with the highest adjusted odds of getting all of their diagnoses wrong were located in Yerevan. So their adjusted odds of getting all diagnoses wrong, they had over 5 times the odds. Providers in urban areas had over 3 times the odds of getting all their diagnoses wrong. And pediatricians had also over 4 times the odds of getting all of their diagnoses wrong. The one thing I do want to note, there's a caveat with this: pediatricians were only asked pediatrics questions, which were generally appeared to be harder than adult questions. So while I may believe the Yerevan and urban results, I think the pediatricians, there's some confounding factors in there. Further analysis, basically, there's also an appropriate treatment variable. So a third one that is pending World Bank discussion with the SDI team. They need to decide essentially how they're going to code that data. But I think the conclusion we could take away from this is that primary care practice in urban areas and Yerevan is associated with decreased ability to accurately diagnose conditions. And I think potentially the reliance on specialists and the ready access to specialists in Yerevan and other urban areas is probably negatively impacting primary care providers' ability to accurately diagnose some of these conditions because they're relying on their referrals to specialists. Okay, so you've made it through primary care. Now we're going to go on to drug procurement, pricing, and reimbursement. So a really big part of universal health coverage is covering the cost of outpatient drugs. And also it makes sense for the health system to try to control pharmaceutical costs if they're going to be the ones paying for them. So there's 3 big parts to this. And first, I wanted to note that very few pharmaceuticals are covered currently in the basic benefits package. And even those that are covered are often unavailable. So patients are still paying, even if they're technically covered. And I also want you to keep in mind that most out-of-pocket costs are either for inpatient hospitalization or outpatient medications. So about a quarter of out-of-pocket costs are for outpatient medications. And these out-of-pocket costs are often catastrophic, which means they're impoverishing. People go into poverty and cannot afford things because they are trying to pay for their medications. And poor long-term control of chronic conditions like hypertension, which I noted in the beginning, cardiovascular disease is the #1 cause of death and disability-adjusted life years in Armenia. Basically, in Armenia, it's thought to be largely due to inaccessibility of medications. So 3 main factors with the drug policy. So drug procurement. This has to do with who procures the medications and how. So main things here for background is bulk purchasing is generally cheaper. You have bargaining power and you have discounts. This is what Medicare is now going to do with insulin. And the centralized procurement is basically one major way to do that. The tendering process needs to be very clearly established to avoid corruption in any country. Then there's drug pricing. So what is the maximum price of drugs and how are these prices determined? This is also, I think, something that Medicare is working on. So countries often regulate the maximum prices of drugs by their international non-proprietary name. So it's basically their generic name to control costs. And they do this in 2 ways. There's external price referencing and internal price referencing. So the external version is basically looking at other countries and seeing what they are paying for drugs. Internal is looking within your own country and seeing what you are paying for drugs. And usually countries use some combination of the 2 because they want to be competitive. They still need to get these drugs and they want to make sure that it's a reasonable price within their country, but they don't want to pay more than is necessary. And then when we think about the pharmacy retail drug price, it's actually a bunch of costs are in there. So basically, you're going to have your manufacturer or importer price. Those are generally treated more or less the same. And then you've got a distributor or wholesaler markup. So the middleman marks it up. And then you also have the pharmacy and retail markup. And then this is all times the value-added tax. So a lot of countries will make a lower value-added tax. Armenia has not for its pharmaceuticals. It may when it finds that it's paying for them. But currently the value-added tax in Armenia is 20%, which is a lot. So, and then finally, you've got the drug reimbursement, which basically is how we would mentally think about what part of drugs is covered by, in our case, in the United States, insurance, but in this case, it would be universal health coverage. So which drugs are reimbursable and how much is reimbursed? So generally, the way countries will go through this is first, they need to update their essential medicines list. Then from the essential medicines list, they will define which medications on that list are reimbursable. And I want to make sure I'm clear here. This is mostly for outpatient medications. There's a different system, more or less, for inpatient medications for the reimbursement portion. Usually it's bundled into the hospital stay. And then the third step is deciding what percent you're going to reimburse of the maximum price. So usually you're going to set a maximum price that you're going to reimburse, and then whether or not there's a copay. This is really intricately linked with the budgeting portion because you need to know how much people are consuming these drugs. So, what's the anticipated pharmaceutical consumption? How much do you think you need to cover and provide? And then what is the pharmaceutical budget? Because you can't know how much you can reimburse without knowing your pharmaceutical budget. So the portion I've mostly been working on is the reimbursement portion. So it's been a lot of fun with Google Translate. We go back and forth and put a lot of comments in, but basically I've been focusing on the reimbursement section and the procedures for calculating reimbursement. So basically, what is going to be the methodology for deciding which medications are reimbursable? This usually in a country that is still, developing its funds, it's going to focus on generics. So nothing that is not off patent. But you also need to include a process for determining how to add new medications to that list that will be reimbursable as the pharmaceutical budget grows and as the UHC budget grows and as the medication proceeds through its life cycle and will eventually come off patent and become less expensive. How do you determine the percent reimbursement? So is it going to depend on a health technology assessment, which assesses the cost effectiveness and the drug and the efficacy, or are you just going to blanket reimburse everything 100% regardless of whether you think that this drug is more or less effective or more and cost effective? Are the reimbursement amounts going to be the same for all UHC populations, irrespective of their income, or is it going to be different based on your income? And is there a copay? And does the presence of a copay depend on the individual income? And in that case, is there a maximum copay limit? And how do you treat brand name versus generic? So we have been talking to other former Soviet places. We've been working with the Ukrainian government, actually, which has been very interesting to understand their relatively recent experiences in this matter. So in their case, they started with all hypertension medications being fully reimbursable. They didn't touch any other medications. They just said all hypertension medications are going to be fully reimbursable. And then they went through a stepwise process of adding more medications by disease category. So they didn't touch the cancer. They didn't touch anything else. They just said, we're going to cover all hypertension medications fully. They did not do a health technology assessment. They realized internally they did not have the capacity to do this assessment of cost effectiveness and efficacy. And they didn't prioritize or have any differential reimbursement of hypertension meds. They realized that was not within their capacity to do that. Yet, maybe later they'll have this health technology assessment. They decided the reimbursement amounts were the same, 100% for all populations, and there was no copay. They didn't want to get different categories of people that were basically competing to be in a lower category, so they had higher coverage. And they only covered the price of generics. So basically they only covered, they had a ceiling for the cost of the generics, and anything that was above that was not covered. So that was Armenia's, and I think it was very helpful to speak. It's been helpful to speak with them and hear what their experience has been, because they've very recently been working on this, although now they're dealing with a whole other set of issues.
Haley,
Okay.
if we can just ask, we'll go through this quickly. We're hitting the top of the hour here, so we want to have enough time for Nathan to present as well.
I have like 2 slides. Should I finish them or just skip them completely?
I think we can go through them very quickly if you're okay with that.
Okay. So the last thing is the provider licensing and registration. We just did a roundtable. As I noted, basically there's been no licensing of providers since 2001. They suspended it when there was concerns about there was concern about corruption and whether the test was fair. So they suspended it and they did not reintroduce it. The Soviet Union did have a system and Armenia did have a system before, but there was just concerns about it. That this has resulted in some variable quality of providers and an inability to both regulate the minimum provider standards and also the provider distribution. So there's no way for Armenia right now to help influence how many primary care providers there are versus specialist numbers. So this is a picture of the provider licensing and registration roundtable that we had. Here's some quick slides. I'm not even going to touch on them, but this is some of the quick slides. And then based on this talk, the part of the Ministry of Health recently discussed licensing and registration with Parliament. And then finally, I just wanted to note this internal capacity building. Basically, there's been a wonderful exchange of ideas going on in the Ministry of Health, technical and conceptual. There's been a huge number of partners. And I think that coordinating everyone, all the cooks, everyone wants to help. It's a central challenge, but a real upside has been the Ministry of Health openness to work with all these individuals and everyone getting a lot of exposure to different ideas and opinions, like whether or not they're enacted. I think this openness to working with people is really excellent. Okay, finally, I wanted to say thank you very much to the Promise Armenian Institute, Shnora Kaluchun. It's really been a life-changing experience. I know that sounds cliche, but it's true. I've met so many wonderful people in Armenia and really had an amazing experience. I want to say thank you to Dr. Shakardemian for always being my biggest promoter and giving me the opportunity to work in the Ministry of Health. The Ministry of Health for having me, Google Translate, and then some quick pictures, and then on to Nathan and lung cancer.
Wonderful. Thank you so much, Haley. And I think once you stop, or Nathan will be now sharing his slides. Let me just remind our viewers, if you have a question, please type it into the Q&A, which you will see as a possibility at the bottom of your Zoom link. So Nathan, we will now turn the webinar over to you.
Thank you. So the title of my talk today will be Perceptions of Lung Cancer Screening Among Armenian Male Smokers. So primary and secondary prevention of non-communicable diseases is a growing priority in Armenia, as 93% of deaths are due to non-communicable diseases, which do include lung cancer. Specifically, Armenia has twice the global age standardized incidence of lung cancer, and lung cancer incidence and mortality is significantly higher in males compared to females. Part of this is due to the fact that over 50% of the adult male population smokes compared to 2% of females. In Armenia, 22.5% of all male cancer diagnoses are lung cancer, with over 80% at stages 3 or 4. Because of this, Armenian men ages 60 to 80 had over a 1 in 20 chance of dying from lung cancer. Previous studies have found that there's a significant mortality benefit in detecting early stage lung cancer via low-dose computed tomography, yet there is no organized screening program at the time. The objective of this study was to understand how Armenian male smokers' beliefs would affect lung cancer screening participation, and the research was guided by 3 questions. 1, what are the perceptions of Armenian male smokers regarding lung cancer screening? 2, is there any relationship between the perceptions of risks, benefits, barriers, and self-efficacy regarding lung cancer and screening? And lastly, do their demographic characteristics impact their beliefs about lung cancer and screening? For our methodology, male smokers aged 40 to 70 with no prior history of lung cancer or LDCT lung scan were recruited from the 12 administrative districts of Yerevan. The survey was administered to 401 consenting participants using Qualtrics. Demographics, tobacco use, and Likert scale responses on 4 validated health belief model constructs, perceived risks, perceived benefits, perceived barriers, and self-efficacy were collected. In terms of data analysis, descriptive statistics, stepwise multiple linear regression, and correlational analysis using Spearman's row coefficient were performed. In terms of our specific recruitment and sampling methodology, verbal screening consent was obtained prior to asking 4 screening filter questions about age, smoking history, and LDCT history, and verbal informed consent to participate in the full survey was obtained from eligible participants and then documented by the surveyors. The surveyors were verbally administered by the surveyors, and the de-identified results were electronically recorded. And finally, the surveys that were at least 95% complete were included in the data analysis for a total of 401 completed surveys. In terms of demographics, most of the respondents were married, completed secondary education or higher, and had an annual income between 100,000 and 300,000 dram. On average, respondents smoked 22 cigarettes a day, which is about 1 pack. Notably, a third of respondents were younger than the recommended screening age, which is about 50 to 80, but over 2/3 of respondents had already smoked the 20-pack year criteria for screening. In terms of results, for perceived barriers, nearly 3/4 of respondents felt they were at risk for lung cancer, but over half also reported that their risk was the same or lower compared to non-smokers. This result demonstrates a concerning lack of awareness of the strong causal relationship between smoking and negative health effects like lung cancer. However, respondents did feel that lung cancer diagnosis was felt to carry a high risk of death. In terms of perceived benefits, 85.7% of respondents agreed that a lung scan could help detect cancer earlier, but only 61% agreed that this would improve their mortality. Less than half of respondents felt that a lung scan would help them plan for the future, which indicates a sense of diagnostic utility. However, more respondents did feel that the lung scan would help their families worry less. In regards to perceived barriers, the most commonly agreed upon barriers to undergoing a lung scan were absence of symptoms, cost of scan, and paying for treatment. Specifically, 75.5% of respondents might put off a lung scan in the absence of symptoms, and 47.7% might put off a lung scan because they didn't have a family member with lung cancer. Notably, almost 1 in 2 respondents indicated a lack of trust in the healthcare system. In regards to self-efficacy, most respondents felt at least somewhat confident they could coordinate a lung scan if needed, and they also felt confident they could arrange transportation for a lung scan. Respondents also felt confident that they could get enough information about having a lung scan. Furthermore, 2/3 of participants had already smoked more than 20 pack years, which is the inclusion criteria for LDCT screening. In regards to multiple linear regression analysis, increases in self-rated health scores were associated with an increase in perceived benefits, while increases in education and income were associated with decrease in perceived barriers and an increase in self-efficacy. In regards to the correlational analysis, there was a positive correlation between perceived benefits and self-efficacy, and negative correlations between perceived benefits and barriers and self-efficacy. So some of the conclusions that we came to are that there is a high potential to reduce lung cancer-related deaths in Armenia, but central health beliefs and barriers limit screening uptake and effectiveness. There are concerns about costs, payment, and trust in the healthcare system that will need to be addressed prior to piloting an organized screening program. Improved education and appropriate recommendations for screening may also be useful to overcoming the previously mentioned concerns. In regards to next steps, we propose addressing the following knowledge gaps. Further education is needed regarding the risk of tobacco use and the importance of tobacco cessation. Further education is also needed regarding the primary goal of screening, which is to increase early detection of early stage cancer, which are more readily treatable, ultimately resulting in reduced mortality. Finally, exploration of cost effectiveness of a national lung cancer screening program and evaluation of the physical and human resources needed for a successful lung cancer screening and treatment program are needed. That concludes my presentation, and thank you to the Promise Armenian Institute for funding this research, and of course, thank you to Dr. Shakardemian for mentoring.
Great. Thank you so much, Nathan and Haley, for 2 excellent presentations. Very eye-opening, and this is just another example of the broad basis under which our Promise Armenian Institute operates in terms of supporting research in many areas, including healthcare outreach. So as is indicated in the chat, if you have, in our Zoom audience, if you have a specific question to address to either Dr. Haley Tupper or to Nathan Chu, please type it into the Q&A box that you see at the bottom of your Zoom screen, and we will offer as many as possible to our speakers. So Shant, would you like to pose a question, or I can, for our speakers to kind of get things rolling here?
Sure, I'll take a stab. So, Haley, you very nicely demonstrated how the development of data, of research output can in real time advise policymaking. But you've also been embedded within the Ministry of Health, sort of like your residency, where your training program is divided into service and education. And here you're sort of divided between generation of data and research recommendations, and then trying to also assist with the implementation of that research into policymaking. In your assessment, putting you on the spot here a little bit, what are the things that we have going for ourselves at the Ministry of Health in Armenia that allow for the seamless integration of evidence and good data into policymaking? Maybe if you can list one to three, and then what are some of the barriers to that you've experienced over the past year?
I think one of the strengths that the Ministry of Health in Armenia has going for it is that I think it's coming from a place where it's actually very interested in the numbers. I think that historically there's been a lot of interest in counting and keeping track of, how many providers you need, how many hospital beds you need. And I think that historically has been very strong. And I think that interest in counting and adequately distributing is not gone. It may have gone under the surface, but I think there is still a lot of interest, for example, in counting the correct number of providers needed and the right inputs. I don't think that's gone. And then I think the second is, even though that's hard to have all of the, you've got all these different cooks, and really getting the intersectoral collaboration is probably one of Armenia's biggest challenges. And it has, to its defense, it has a ton of people in there trying to cook and do things. There are some very strong organizations that are working there, especially, for example, that it has AUA, it has its own institutions. It's not like it's completely relying on the World Bank. I think it's just a matter of effectively using each other. It doesn't have to start from scratch, though. It's not like these people are completely missing. And then what was the second part? I think I've kind of weaved it into my answers, but
I think sort of advantages and disadvantages, or enablers and barriers from evidence to policymaking.
Sure. I think while they have these resources, I think part of it is just asking the right people the right questions. As you've noted, people, once they get the data, they're usually very happy to have it. But it's a matter of asking the right questions and thinking of things that could be useful, and then just going and carrying it out yourself. So it has to be a lot of self-starters. And I think having people in the ministry is helpful in terms of thinking of what kind of questions are useful for the government. But I also think that's a barrier too.
Great, thank you. Anne,
So
anything from your end?
I can ask a couple of questions, and then we'll go to our audience questions. Maybe Nathan, I was struck by the significant difference in the population in Armenia of male smokers as compared with female smokers. Do you have any thoughts about education, certainly testing and encouraging scans and so forth that could be addressed, but specifically with respect to those gender differences?
Yeah, definitely. So I think in regards to tobacco cessation and tobacco education, Armenia is definitely working towards more efforts for tobacco cessation. I know that they have increased tobacco taxes, and they also have mandated tobacco warnings on the packaging. And they've also recently, I believe, they've banned indoor smoking in some areas. So I think those are all measurable steps towards tobacco cessation. And those efforts will also go towards educating the population about the dangers of smoking, especially I think the packaging on the tobacco packages will definitely go a ways, but I think there's definitely still room for improvement and increasing that education.
Great, thank you. And a quick question for Haley. One of the many disturbing, let's say, and surprising items that you mentioned is the lack of regulation of the physicians and licensing and so forth. Do you believe, there is a movement now in the Republic of Armenia to have better and deeper training for the nursing population? You might be aware at AUA, they have a BSN nursing program with, far more scientific education provided for nurses. Do you think that will have an impact and perhaps encourage not only licensing, but a more rigorous kind of approach to physician education as well?
First of all, yes, I definitely think it will help, because I think as you have nurses that are capable of, they're more comfortable with doing more, then it basically raises the bar for providers as well. So I think that is, having that nursing training is huge. We're well aware of it. Someone we work with in the Ministry of Health has been participating in some of their conversations. So I think that having, the nursing training for both primary care and specialty care is enormous, but especially primary care, I think that they can be a huge help there. And I think they will raise the bar, and just having that level of training is really excellent. With regards to the licensing and regulation, I don't know. I think it's hard to say. I think that's a bit on the government. And I also want to acknowledge that regulation and that licensing is only good if it's fair, and it's only good if it's enforceable and enforced. So I think that the licensing and regulation is complicated. I think it is really important to attempt to do that. And I think it's reasonable to attempt to do it for both providers and nurses, since they're both taking care of the patient. It's just often a logical start is with the providers, maybe because they have more, typically have more responsibility at the end of the day. But I do think that it's important to license both. And I think that having a strong training program for the nurses will definitely help with the quality of the providers as well. And maybe someone will get the idea about the licensing as well.
Great, thank you. Sean,
So
do
it
you
looks
want
like
to
we
ask?
have a
Questions.
few
Go ahead.
questions from the audience here. Maybe we can just go in order. So interesting question here. It says, is there any comparative data between Armenia and Abkhazia? And if so, what are the differences? I'm not aware of any, but oftentimes, okay. Let's see. I would just say that putting the political nuances aside, data that is available for us for assessment and review is almost always at the national level. And so it's unusual for us to come up with or come across data that's specific to a certain region. And so we have a fair amount of comparable data. And in fact, there's a lot to learn from the Georgian experience, also former Soviet, former Semashko system, but went a very different route after independence compared to Armenia. And there is some pluses and some big minuses actually of the Georgian system that fortunately Armenia did not go through. But comparing Armenia to Georgia, certainly there's a lot of lessons that could be learned for both countries in that comparison. I'm not aware of anything with regards to Abkhazia proper. Let me ask the second question, and then I'll turn it back over to you, Anne. What systemic strengths do you see that can be helpful in the implementation of various programs? Maybe a runoff or a continuation of my question, but what are some of the strengths, I think, if I'm interpreting the question correctly, that you've witnessed or seen that could be helpful in the implementation of these reforms?
I think that if there's some effort with the coordination. There's a huge number of people that want to help, diaspora and local. I think that the hands are there. It's a matter of coordinating them. So it's not that there's a shortage of people or resources. It's really a matter of thinking about what those people have to offer, and then the country itself really directing those resources. So I think that having a strong vision and priorities for the country would be very helpful, and some comfort with being able to tell people who want to help what they need and what they do not need. So because they don't have a shortage, I think, of funds, people that want to help. I think that's an enormous strength. It's really just a matter of sending people in the right direction, and acknowledging, you know, this person maybe only has 2 weeks, this person has a year, this person lives here, this person has this expertise. And how does that fit within our national priorities? It should be the country really telling people what they need, and they have a huge number of people that are willing to help. So I think that is a huge strength that could be leveraged to help with the implementation. Just a matter of dividing and conquering.
Okay, thank you. Another question, which may be very difficult to answer, though, is what is the probability, or what is your opinion, Haley, on the likelihood that the 2027 universal health care requirement or goal will be implemented based on the current situation, at least as you see it?
I think it will be implemented in some capacity. I think that universal health coverage by nature is a stepwise process. So I think that they will implement, you know, their first step most likely. It may look slightly different than what they think it's going to. I think that their strategy is to pick a segment of the population and roll it out there, and then expand in the population, you know, versus some places where they choose to cover a smaller segment of disease and then roll out the available things. So it may not look exactly like what they think it's going to. It may be a smaller version. It may be more disease focused rather than broadly covering, for example, dialysis, which I do not think makes sense to cover initially for a country that doesn't have a lot of resources. I think it may look different, but I think that since universal health coverage is stepwise, I think they will have rolled it out to some segment of the population by 2027.
Thank you. And just a follow-up question on the nursing aspect. Would you like to ask that one, Shant, or I can?
I can read it too.
Yeah, okay. So as you know, the Ministry of Health has set up a commission for nursing national examinations, and potentially, I suppose this is related to the new program from AUA. Do you know if they will have the ability to conduct psychometrics on test items?
I think that they probably will not. I think it's a huge process, and you can, if you're looking at the psychometric properties of test items, there's not enormous, but there's quite a few items that you can evaluate. You can do the test, retest, reliability, content equivalence. You could do a principal component analysis. There's a ton of different ways to evaluate the psychometrics of a test. So it's pretty time intensive. I suspect that they will not do this just because of how involved it is. Hopefully they will have someone check whether the translation is accurate if they're translating it, and whether they will, and hopefully they'll have someone trial the test a few times before they deploy it. But I don't know if it'll be reasonable to evaluate it like psychometrically.
Thank you. Let's see, Shant, would you like to ask?
Yeah, it looks like there is a methodology question for some of the research that's been done regarding the survey data. Do either of you have any comments on response rates and the non-response bias? Was there any adjustment that you did for the?
So no, we did not adjust for any non-response bias. We note it as a caveat in all of our studies that this is a limitation that we did not adjust for it, and we didn't even in most studies account for it, especially when it involved like filter questions in the beginning, or if people were not interested in participating from the get-go. So we, with the response rate, while we note it as a limitation, and the non-response bias we noted as limitation, we did not adjust for it.
Thank you. Let's see. There's one question I've had, and that is, as you may be aware, there have been a number of groups in the diaspora that have sent medical teams to the Republic of Armenia, medical and sometimes dental as well, and they treat patients, particularly in the rural areas, who do not see a primary care or any physician with any regularity. I mean, I know that's had an impact, but it's an attempt to make up for challenges in the medical system and in healthcare in Armenia. Did you, either of you, see any relationship between that and an appreciation by the physician population in Armenia, or any understanding of what the benefits could be for bringing these teams in to assist, perhaps even in education?
So we spend most of our time in Yerevan, so I have to acknowledge that that's a limitation. We're not hugely in rural areas where these people would be visiting. But I think that there is potential to share, like, especially if it's with an education focus and you're able to educate people. And if you know that there's not curriculum, but there's specific things that the country is trying to educate their primary care providers on, I think that there will be a huge potential for people that are coming to either do missions or help with something to be able to educate on these specific topics and really push things forward in a way where they're able to prioritize some of the country needs. So I think, like I said, it would be a huge coordination issue, and it's always helpful when people do the missions. But I think the best is if you can leave something with the providers that can stay. So if there's a way to, even if you had one rural area, I think sharing how things are done, even if not just the United States, but anywhere, is something that can be really helpful. But it's best if it can be aligned with what they need. For example, if they needed education on the electronic health records, maybe that's something that they need a little bit of teaching on, then I think then you can do your mission. But if you could also help accomplish this one thing, that would push the priorities forward.
Great, thank you. I think we are just about at the end of time. What we, of course, will be able to do is forward to both of you any additional questions that do not get asked during the webinar. So I think, is there anything you'd like to conclude with, Shant? Otherwise, I will kind of conclude the webinar myself.
No, I think you mentioned that there are some other additional comments that on the chat that we can share with our presenters, but other than that, no, nothing from my end. Thank you very much to the both of you for excellent presentations.
Great. Well, thank you from me as well, Haley and Nathan, for a very stimulating pair of presentations, and we wish both of you all the best in your continued research and education and training activities. And we're very grateful to both of you for your efforts on behalf of the Promise Armenian Institute and on the improvement of healthcare in the Republic of Armenia. So now let me close our webinar by noting that the Promise Armenian Institute has several additional events that are planned in the near future. In fact, tomorrow, on Friday, May 26th, beginning at 12 noon Pacific, there will be 2 events in person on the campus for the UCLA Armenian Music Program. At noon, there will be a day of Armenian music presented in Schoenberg Hall, and then followed at 5 p.m. by a free concert that will feature the internationally acclaimed composer and pianist Artur Avanesov. And this will be in the Schoenberg Music Building at Lonnie Hall. On Wednesday, May 31 at 10 a.m. Pacific, the Armenian Genocide Research Program within our Promise Armenian Institute will present a discussion and interview on the subject of the Hamidian massacres of 1894 to 1897, Challenging Traditional Perspectives. And this will be conducted by Dr. Yela Verhey and Dr. Owen Miller. And finally, to round out our academic year, on Saturday, June 3rd and Sunday, June 4th, from 10 a.m. to 5 p.m. Pacific, Professor Peter Cowie and Dr. Hirash Mardirosyan will host the second annual Armenian language workshop here at UCLA in Bunch Hall, room 10383. So for these and all other Promise Armenian Institute events, please consult our website or social media to see more details on our programming. So finally, in closing, we'd like to offer our grateful thanks to our Promise Armenian Institute Deputy Director, Hasmik Bagdasarian, who has worked so energetically and effectively in coordinating all aspects of this event. So thanks once again to all of you for your attendance at this webinar, and we will look forward to having you participate in future events for the Promise Armenian Institute at UCLA. Good day to all.